What is the key to achieving a successful regenerative surgical procedure? Is it hours and hours of training? Is it learning techniques from the gurus? What about case selection? Is it performing a procedure over and over again until you can do it with your eyes closed? Using the most current or expensive armamentarium? Or is it using the best quality materials? The truth is that all of these things probably contribute to your surgical success. But even if you are highly skilled, experienced, and have mastered a technique, there is an unspoken cause of surgical failure that still lurks in the corner. Some surgical failures are out of our control, but others are avoidable. These are caused by human error. Avoidable failures are frustrating and demoralising, and as the complexity, knowledge, and skill required to perform regenerative surgeries increases, so do our chances of avoidable human errors. Pilots, much like us, need to work in a team environment and have jobs that require high levels of skill, extensive training, and when things go wrong, they can be devastating. Aviation has a strong record of investigating failures, airline crashes, and an outcome of this has been the development of a checklist targeting human error. The most commonly used of these are for 3 critical areas: takeoff, approach, and landing. Checklists have also been recommended and implemented in medicine. The World Health Organization developed the WHO Surgery Checklist, designed for the use in hospitals to make surgeries safer. They were able to show that implementation of this checklist reduced major inpatient complications and the inpatient death rate. The WHO Surgery Checklist has a total of 19 checkpoints, which are carried out over 3 critical time points: before anesthesia, before incision, and at the end of an operation, or in aviation terms, takeoff, approach, and landing. What if we could have a checklist for our surgical procedures? One that could reduce avoidable errors, decrease stress, and make surgery safer. How would you go about designing a checklist for regenerative surgical procedures? We aren't pilots flying planes, and we routinely aren't surgeons in operating theatres, meeting our clinical team for the first time minutes before we make the first incision. It's important that we design our checklists to work in a dental surgery. First of all, let's compare a good versus a bad checklist. A bad checklist is impractical, too long, wordy, and difficult to use. They are not appropriately designed for the circumstances in which they will be used, and they assume that the people using them have no idea what they're doing. A good checklist is the exact opposite. It is specific, to the point, simple to use, and there is an assumed level of skill and knowledge about the individuals who are implementing it. A good checklist does not tell you how to perform surgery. It prompts an already skilled surgeon to carry out highly complex and sophisticated procedures with the reassurance that they are performing treatment reliably, safely, and predictably every single time. The look of your checklist is also important. Minimize distracting colours, use a font that is easy to read, and limit it to a single page. I recommend that you use a do confirm style checklist, which allows more freedom to complete the checklist from memory prior to consulting the list. This is opposed to a redo style list, which is more like a recipe that you need to follow. Your checklist should be designed to be used at critical time points. For example, at your consultation appointment, in the days leading up to surgery, and on the day of surgery. These are your regenerative surgery version of takeoff, approach, and landing. Next, we determine the items which are key to the success of your surgery at each of these critical time points. Your takeoff checklist, which is conducted at the time of consulting with the patient, may include such items as periodontal status, defect dimensions, recession measures, discussion of grafting materials, or referral of diagnostic scans. Remember that a good checklist is designed for the particular circumstances in which it will be used, so a list may not be ideal for what you need. You may find that incorporating it into your appointment notes by having a pre-written template is beneficial. For example, I have a unique template that I've created for every type of consultation that we perform. During a consultation, my assistant will have the template on the computer. I will conduct my consultation and examination from memory. My assistant fills in the template from the conversation with the patient and as I talk through my examination findings. Then, prior to me sitting the patient back up in the chair, my assistant prompts me if I've forgotten anything on the template. So, there you have an example of how a checklist has been incorporated into a consultation. It's up to you as to how detailed you make this. You can have as many items as you like, but remember that a checklist that is too detailed and too long becomes a bad checklist. The approach checklist is done prior to your surgery date. Items here may include: have the appropriate diagnostic scans been carried out and reviewed? Is all the required equipment available? Have all the necessary regenerative materials been ordered and arrived? This allows you to avoid a situation where, for example, the particular grafting material that you need may have run out of stock, or equipment that you require is off being serviced. I again have surgery-specific checklists, and checklist items are either filled in or ticked off when completed. This checklist is not only important for the surgeon as part of planning for the surgery, but also imperative to the clinical staff to allow them to be fully prepared to set up on the surgery day. The landing checklist is done on the day of surgery, and again, I believe parts of this are best incorporated into the appointment notes as part of a pre-written template. However, it is also beneficial to have a checklist that is carried out immediately prior to seeing your patient, similar to the WHO surgical safety checklist. You can do things such as confirm the surgical site, review the medical history, medications and allergies. The surgeon can brief the assisting staff about the critical aspects of the case and anything else that they need to be aware of, and the assisting staff can ask questions or raise concerns. This step is important because by pausing and discussing the surgery, even in brief, it brings about an essence of teamwork and shared responsibility. Who is the best person to be responsible for the checklist? It could really be anyone on the surgical team, but let's be honest, there is a reason why on aeroplanes, the captain doesn't carry out the checklist, and why a nurse in the operating theatre is the one that runs the show. Sharing the responsibility of performing the checklist makes it clear that it is not just the surgeon who is responsible for surgical outcomes and patient safety. It's a team effort. Once you have created your checklist, it's time to test it. I can guarantee that your first draft won't be your last, and as you use it in real life situations, you will be able to see what works and what doesn't, and amend accordingly. multiple versions are required to achieve the ideal checklist, and you may find that you will need to tweak it occasionally. There you have it, your guide to creating a regenerative checklist. So now I want you to think about how you operate, how you conduct your surgeries, and whether implementing something as beautiful and simplistic as a takeoff, approach, and landing could improve your treatment success, patient safety, and also reduce your stress. And finally, I'd like you to ask yourself, if you were having an operation, would you want your surgical team to use a checklist? I'm Jennifer Kraatz. See you next time.